Good afternoon, everybody. I'm Lynn Brown. I'm one of the pulmonary hypertension docs that works at Intermountain Medical Center in Salt Lake City, Utah. This is Infused Therapies. If everybody's in the right place, hopefully, we're going to talk about the various IV and subcutaneous forms of medications. Let me introduce everybody. The redhead is one of my good friends, is Deedre. She is a nurse coordinator, and she is going to be your friend because she's the one that brought the pumps with her and knows everything about the pumps, the lines. I think she even brought a line with her so you can kind of feel and touch. Deidre's a nerd, and everything she does, she has to touch and hold on to and play with, so that's what she brought for everybody else. So if you've not been able to get up close to one of the pumps, we can do that. Namita Sood is in my middle. She is a doctor at Ohio State University, and John Ryan is also a physician, and he is at the University of Utah. Just to get us started a little bit about infused therapies, sometimes we refer to these as our advanced therapies. They also sometimes can be called parenteral therapies. And the reason for those two names is that these are some of our best drugs. They really work. We know that they do. We know that they improve survival. And we have the most experience with them. Flolan, which is one of the medications we'll talk about, has been on the market for decades, and it was the first medication that was ever approved for patients with pulmonary hypertension. So we know a lot about these different medications. And sometimes people ask me, well, if they're such great medications, why then do we have to use the intravenous forms or subcutaneous forms and have to have the pumps? And it really comes down to the types of medications and molecules that these drugs are. It would be a lot easier to take a pill, but for pills to work, they have to be able to be stable throughout your body, especially through your GI tract, and be absorbed into your body where they need to go. These medications are very unique in the fact that they can't tolerate being swallowed. The stomach acid would dissolve them in minutes and not be able to absorb them into the body. And so instead of taking them by pill, what we end up doing is infusing them either through a vein or through a catheter that goes just underneath the skin. And those medications are then able to stay in the form that they need to be in to get to the rest of your body, especially to the blood vessels in your lungs, which is where the problem is. I don't want to talk a lot about mechanism of action because I could speak up here all day about that, but basically it's what you guys know, is that pulmonary hypertension is a problem with the pulmonary arteries. And in most patients with pulmonary arterial hypertension, those blood vessels in the lungs, which should be nice and big, have gotten a lot smaller. And all of these medications, especially the ones we're going to talk today, take those blood vessels that have gotten smaller and they open them up so that more blood can flow through those tubes. And so it's very, very helpful as far as what they're able to do. Some of the options that we're going to talk about today involve different drugs, how they're prepared, what their half-lives are, which means how long do they stick around if you keep them sitting on your counter, and how long do they stick around in your bloodstream when you start using the various medications. So I'm going to stop there. What we're going to have is Dr. Ryan's going to talk about some of the intravenous therapies. After Dr. Sood talks a little bit about how we choose which patients we put on these therapies and how it's kind of a matter of matching the patient to the right drugs. And then Dr. Ryan will talk about, as I mentioned, the intravenous therapies. And I left Deedre, who just did her master's thesis on subcutaneous remodulin, so she is by far an expert on it and stuff. And like I said, she brought all the pumps and everything. So with that, I will let Dr. Sood talk.
So you heard that these drugs are sort of a little bit more complicated than taking tablets. And so when we first started developing drugs for pulmonary hypertension, actually the intravenous epoprostenol or Flolan was the first medication that was available to us for the first 5 years before the tablets came about. And since then, multiple different types of tablets have come into the market that have been effective. So the question becomes, why do we still keep using these very complicated medicines, which has to be given by a line that is placed in the vein or by a catheter that is placed under the skin, and the patient is pretty much hooked to that pump 24/7 for the rest of their lives. So why do we still use this complicated drug system? The reason is that for the sicker patients, so when we are catching patients who are a little bit more advanced in the disease state, then those are the drugs that works the best. we know that when we have a patient with pulmonary arterial hypertension and their right side of their heart is starting to fail, if with whatever treatments we use, it could be tablets or the pumps, if we are able to get them better to the point that they're up and about, able to walk, do most of their activities without too many symptoms, then the patients do better long term. So it's not about keeping somebody alive 2 months, 3 months from their diagnosis, but thinking 5 years, 10 years, 15 years ahead and wanting to keep them well. And we know that if we are able to improve the function of the right heart, able to keep them up and about, then they do better. So whenever we get somebody who is really in advanced stages, that means they're quite short of breath, with minimal activity, have evidence of the right heart failure, that is swelling in their legs, swelling in their belly, get short of breath with just minimal exertion. And when we do their workup, we find that on the echocardiogram, the right ventricle looks like it's got a lot of strain on it. And when we measure their pressures and their cardiac output on the right heart catheterization, we notice that the pressures within the right side of the heart are pretty high, the heart's just not pumping as well. Then these drugs become the best drugs to use, because when we use them, we can get all that to improve relatively quickly, and then get the patients from, say, a 1 or a 2 to a 5 and a 6, and then things start to improve further. We realize these drugs are complicated, and you'll hear that from the rest of the people in the panel, but those are the patients we select out for that. The other category of patients would be that they come to us not so sick, but we've started with tablets, 1 tablet, 2 tablets, maybe even inhaled therapies, but they continue to either not improve as much as we like them to improve, or they improve and then start to decline again. Then we can use these medications to get them better and keep them well. So I think that's how we select. In this day and age, we select patients for infusion therapy. Having said that, literally 20 years ago, that was the only drug we had, and everybody with pulmonary arterial hypertension went on pumps. And much as this disease is so devastating, and I always tell my patients I've stayed in it for 20 years because a few of my early patients that I started on these medications are still alive, and not just alive, they're doing well, like looking after their grandkids and have their jobs and all that. So I think it's the potency of these medications, the effectiveness on them, that balances off the inconvenience that they bring with them, and that's why they stay within the therapeutics of pulmonary hypertension.
So I'm John Ryan. I'm at the University of Utah. I run the pulmonary hypertension program there. First thing, this is a real treat, and if you'll indulge me, I actually want a photo of this room because this is just absolutely fabulous. So if you can put your hands in the air or do something celebratory, that'd be really great. There we go. Thanks. And so I'll post that later. So also what I want to get a sense of, so who do we have here? Do we have people who have pulmonary arterial hypertension, if we can get a sense as to who that is? Okay, great. And thank you for coming. And then do we have people who run pulmonary hypertension programs, MDs, NPs, MAs, PharmDs? A handful. And then we have some industry folks here as well, I think, right? Thank you. Thanks for all the support you guys give. This is a real treat. And purposefully, we actually removed the term patient from our clinic about 6 months ago now. Because we felt, because ultimately folks who have pulmonary arterial hypertension, they're actually experts, because they live with this disease every day, and they're experts with these pumps. And we just felt that referring to people as patients resulted in this hierarchy, that we had all the answers when in actuality we don't. But there are 3 medicines that are available in the intravenous forms that we're going to touch on. And it gets very confusing. I was talking to some folks earlier, and because the language changes and we go from trade names to generic names. But the 3 main medicines are Flolan or epoprostenol, as Namita referred to, was the first medicine we had in the mid-90s and the first medicine that was approved. And then room temperature stable epoprostenol, or Velitri, was approved. And this ultimately has a different diluent. So this is a medicine that has arginine in it instead of the glycine, and that's why it's room temperature stable. And really liberated people quite a bit, because instead of having these pumps where you had ice packs inside it, obviously gave a lot of freedom to folks, and as our reps in particular are familiar with. And then there's Remodulin, which is treprostinil. Remodulin is the trade name. Treprostinil is the generic name. And this is available, to further confuse things, this is available in two forms, intravenous or subcutaneous. And as Lynn referred to, really all of these we refer to as parenteral, meaning that it's some sort of infusion that goes inside the body. So the Remodulin is intravenous or subcutaneous. There are subtle differences between these. The main one being is that the Flolan has a shorter half-life. So whereas the Remodulin, the half-life of the Remodulin is a couple of hours. And this is important in particular for discontinuation and those of you who are at the Journeys lunch, which was an incredibly touching lunch. Particularly we had Colin from Colombia whose PICC line broke, for those of you who were there. But there is a half-life associated with Remodulin that gets you some time to get to the hospital. So that's, and me, Lynn and Deedre primarily use Remodulin, really, at least our program. Because we're obviously in Salt Lake City, we have large numbers of people who come from hundreds of miles, and getting people to the hospital within a time period that's comfortable with Remodulin is important, if there's a problem. So that's kind of one of the main ways to choose it. And then the other kind of, so one fork in the road, I think, is are you choosing epoprostenol, Flolan, or are you choosing Remodulin? And then the next fork in the road is are you going subcutaneous or are you going intravenous? And the intravenous comes with, obviously, by and large, you run or there is a risk of infections with intravenous with chronic indwelling catheters, and that's something that some people just are very high risk of or very nervous of, to be honest with you. And then whereas subcutaneous typically goes in under the abdomen, or the abdominal wall, with the catheter located there, but that can come with some subcutaneous side effects mostly. And in particular in the first couple of weeks while you're up titrating the medications, you can end up with a lot of abdominal discomfort, which I think can be limiting. So I think when you're making the decisions for subcutaneous versus intravenous, and hopefully you guys will have questions, but I think the main things that come up is, are you comfortable with having an indwelling catheter, or are you more comfortable with having subcutaneous? A lot of people like the subcutaneous because people are familiar with insulin pumps, and the CAD-MS3, which works with a subcutaneous device, is essentially the same as an insulin pump, and people are familiar with it. You know, folks in their communities have insulin pumps, so there's some familiarity and at least perceived more safety with that. And so I think that goes into decision making. I think once you and your pulmonary hypertension provider have decided that prostacyclins are for you, for the reasons that Namita touched on, then I think it's worthwhile deciding, well, am I going with intravenous? Am I going with subcutaneous? What are the benefits, the risks and benefits of each? What will make me feel more comfortable? And my family members and those around me. And then I guess if, you know, we are the infused therapies, then the focus over the next hour will be on infused therapies. But there are some people who just aren't comfortable with that, so just know with your pulmonary hypertension provider to figure out other options, namely the inhaled therapies, which I think is a separate room. They typically go in a tunneled line. For the intravenous, I just want to touch on this and then we'll pass over to Deedre. Typically a tunneled line. The tunneled line is usually into the subclavian vein or into the internal jugular vein, but usually comes out at a port that people can access and people can see. That requires an interventional radiology procedure or a vascular procedure, depending on your hospital. And occasionally a PICC line will be the other kind of mechanism in which people get started on these medicines. Coming down the road, as the Americans would say, coming down the pike. Coming down the road, there's an implantable pump, which clinical trials have finished on the implantable pump, but the results aren't out yet. Yeah. But you may hear that among your communities. And I'll kind of wrap it up there. The one thing that I will say is that any time these medicines get started, or nearly every time they get started, they are started in a hospital. You're brought into the hospital, you come in, you get your tunnel line put in, you typically go into the ICU, at least that's how we do it, and that's how folks at IHC do it as well. And you're started on medicines. You will notice side effects first, and the side effects oftentimes come on before the benefits, so that can be a little frustrating over the first couple of days. And then typically at least stay in the hospital 3 to 5 days, and then go home on some sort of dose and a dose regimen that you and your loved ones are comfortable with. And in particular, this is really where the CVS care, folks like Specialty Pharmacy, CVS Care, Marta Credos, folks like Deedre, Jenna Lynn, and our program as well as Erin really do a lot of teaching with people. So during that 3 to 5 days in the hospital or a week, that you are, by the time you're going home, you're comfortable with this medicine, you know what you're doing, all your questions have been answered, and you feel comfortable and your loved ones feel comfortable changing these medicines and preparing the vials and so on. So I'll wrap it up there, and look forward to hearing your guys' input.
I'll let Deedre talk, and then we're going to have lots of time for questions, because honestly, if you're thinking it, someone next to you is thinking about it, and a lot of times I want to know what my patients are thinking and not going to ask me. So it's really good to hear what you guys have to say. So I'll let Deedre talk, and then we'll get you some time for questions.
All right, can everybody hear me okay? Perfect. A little up, I'm hearing. I'll sneak it right up here. All right, the one group that I didn't hear from is who are caregivers or people who are family support, friends, because you are just as important, because pH involves everyone. In fact, if everyone in this room who's been affected, their lives have been affected by pH. Everyone. Everyone who's here has had the opportunity to learn more. So I'm going to take a moment. The doctors usually are the brains behind trying to figure out diagnosis and understanding patients. And then they start to ask the patients, because it's very important you get involved in making the decisions on which therapy, especially when we start talking about prostanoids, is going to be right for you. Because whereas we as the medical team understand your case, how your body is working, how it looks, you understand your lifestyle, and that is the most important. And so I always tell people that you are the expert on your life. I'm not the expert on your life, so we work together. So let's talk about pumps really fast. And I brought a whole bunch of things to show, because I think it's scary to talk about things when you haven't looked at, well, what is a pump? What does it look like? So pumps are, you've seen them around on a couple of people. This is the CADMS-3 that Dr. Ryan spoke about. It's generally used for subcutaneous Remodulin. It's about the size of a pager and can just go, you can go in a lot of places. Let's say that. You can hide this and no one will even see it or know. This is the CAD Legacy pump. It's generally used for IV Flolan and IV Remodulin. It's a little bit larger. It goes into a case, and I've seen it in every form of bag known, but this is kind of the cases that it comes in, that people carry it in. If you're using Flolan, it requires some ice packs that need to be replaced around it from time to time. If you're not, if you're using Velletri, and you're in a nice climate, if you're in a really hot climate, Velletri will also need some ice. Or if you're on sub-Q Remodulin, you don't need ice. And so your options of how you can wear this are innumerable. I have seen everything from super swanky pump packs to everything, including poppy packs that can go around your body so that you can hide this pump underneath your shirt and nobody sees it. And then this is the Kronos, which is used, my understanding, for the most part more in pediatrics, but it can be used for IV. And so that's the pump sizes when they're talking about sizes and the pumps that we use. And they're all generally pretty easy to use, and these are not the first set of pumps that were used with the medications. So they're better and easier to understand. And I don't have problems with my young patients. They pick them up and can figure out that pump faster than I can explain it. So they're not intimidating in that aspect. It's something you can definitely learn. People keep talking about catheters. It's a word that we use, and for some people that's a foreign word. And so I just tell them it's simply a plastic tube. That's what it is. We use a plastic tube so that we can deliver medications. One of the lines that we tend to use, I'm going to show you. This is a pick, which is used in people's arms. I just wanted you guys to see, first and foremost, this one's really long. It can be set to whatever size it needs to be. But it's nice, it's flexible, it's easy in that aspect. This can be placed in the arm. Most people go to a tunneled Hickman catheter, which literally kind of looks like this. So if you were to put it on your skin, it tunnels underneath your skin, and it goes in here to the vessels up in your neck. And then because we're a little worried about infection with these, they have to be covered. So they have a dressing on the outside that has to be settled and cleaned appropriately. But there are lots of different types of dressings. And so I wanted to kind of just show you guys that once you start talking about this, there's so many different options. It's like going to Baskin-Robbins and which flavor do you want? So it's not something where you're stuck with one thing. We're here to help you, and the medications are here to help you, so we make them work the best that we can. So one of the other ones, when we talk about doing subcutaneous Remodulin, we deliver that medication through another catheter, but it's super small. In fact, it's going to be so small you guys won't even be able to see it. There's 3 of them right there. They're teeny tiny, they just go right underneath your skin. And there's also different types of dressings or different types of catheter systems that can be used there. Like I told you, lots of different options. And this is generally placed, there's lots of different places it can go, but I see it used the most usually kind of in bellies or arms or maybe the back of your flank or hips. So it can be used right in that direction. And there's a little bit of changes that need to happen. So when we think about a patient and they go, well, what do I need to know to be able to do this? They've got to be able to mix some medications. So some of the medications are a little bit trickier than others. Some of them require drawing up with needles and syringes and just putting it into a syringe. Some of the other medications like Flolan or Remodulin require diluting the medicine down. It comes kind of in a stronger form and we have to mix it with a little bit of extra fluid. And so that's something that we definitely teach people. That's why it seems to be complex. We just have to get it in the right concentration for you. One of the other things, patients sometimes have problems with hand dexterity, especially if they've got connective tissue disease. And so just because you've got scleroderma and maybe a little hard time with your hands doesn't mean you can't use a pump. It just means we have to work together to figure out how to do the pump. Because sometimes there's a couple tricks that we can use. The other thing is just really a nice area that you can have in your house that's going to be clean, and you're going to be able to put the supplies in a locked area. So if people have small kids, I always tell them make sure you have an area that you can keep up and away from the kids. If you have small animals, you don't want to just throw away your medicine into normal trash bags. You want to put it in a trash bag with a lid so that you're not sharing your medications. We all know it's not good to share medications. So we don't want to share them. With this, we also need people a skill to have, and it's something you can learn, is how to respond to alarms. So we talked a little bit about the medication, that it can't be stopped. And so because of that, we usually almost always have one person trained, which is the patient or the becoming expert on the pump, and another person who is a caregiver, a friend, a spouse. It can be ever so different depending on the person. And the reason why we have 2 people trained is not every hospital knows how to run this medication, especially where we're at. There's kind of rural areas. And so we need to make sure that even if for some reason you were not able to take care of the pump, you were to get ill, that somebody who's with you can manage that pump and help you out. So we often will refer to it as a caregiver, a mixing partner, a mixing buddy. You get to choose your own term so that we kind of work together. So with subcutaneous, we try to avoid site infection, so you need to be able to work to kind of keep it clean. It's a little bit more important it's important to avoid infection with either system, let me say that. But it can be a little bit more serious to have an infection in the IV system, since that tube goes directly up and into your bloodstream. And so we have lots of nurses who do lots of education and teaching with patients to be able to learn how to do that. The dressings are occlusive, is a word that we use. I tell people it's like when you want to put your food away in the refrigerator, you wrap it all up nice and tight. That's exactly what we're doing with this, is keeping that site nice and clean and dry. Some of the activities I always like to mention, because people will ask me, what about if I shower? How can I shower if I have something stuck in me? What is going to happen? And so there's lots of different systems we have. I brought one of many that we can use. There are systems where there are plastic with tape around it that can literally go over the site so that you can keep it nice and dry while you have a lovely shower. And if you need it for the smaller pumps like the CAT MS3, they have shower packs that literally you can put the pump in and hang it up next to you while you use your herbal essence and have your moment. So one of the other things is, when I think of activities, a couple of things I always want people to know ahead of this. One, once you have a pump, MRIs, it's a test. You don't need to know much besides it's a MRI test. If you go to have one, they'll say, do you have any metal on you? These pumps cannot be managed in an MRI. We can manage the medications and the systems, but you just have to talk to your caregivers and talk to them. Doesn't mean you can't have an MRI, it just means we need to have a little planning session before that happens. And then with traveling, I always tell people it's really important to make sure you've got lots of extra supplies on hand, because this is a life-supportive medication. And so we always want to have plenty right on hand. You can travel, though. You can continue to live life. The reason we use these medications are to continue living your life. They're here to support you, not you to live to support them. So I think that's one other thing I might mention before we just jump into questions, because I don't know if anyone, and I don't even need to address it that much, but side effects.
Yeah.
For the Q&A session, if everybody can just keep your questions somewhat general. We have about 30 minutes, but I'm sure a lot of you have questions, so just try and keep it as general as you can. Who's first?
I had a lot of sight issue with my sight, and I take antihistamines, Prepsid and Zyrtec. Is that normal with IV?
I was going to say, you said with IV. Is it common
Yes.
with IV?
Yes.
Sight pain is usually not an issue with IV method.
It wasn't necessarily pain, but it was red and itchy, and I would scratch it open, and other things from that.
I would often say that I've had a couple of problems with patients that have had allergies to adhesives and the dressing on the adhesives, and it can be really, really challenging. In fact, I was at my wit's end more than once, where I had to do a whole bunch of lit research and try to figure it out. There are different types of dressings. In fact, this dressing that's down in the corner is a hypoallergenic dressing. And so some patients have been able to change their dressing or the materials that you clean the line with, because you could have an allergy to that.
I have one of those, but what is the dressing hypoallergenic?
There's lots of different types. I'll show you after. Come up after and I'll give you the exact name.
Yeah. And I think it's important as well that these medicines are all vasodilators, and so then the side effects work by dilating blood vessels. So that's why people, as you guys know, look constantly embarrassed, right? Because your face is flushed and so on, and that can drive a lot of irritation in other sites that you wouldn't normally suspect. Your cuts, any scrapes that historically you got can feel a little more irritated than when you get a scrape because you got extra blood flow going to those areas. So I think that so some of it is the way in which, unfortunately, the disease works. That's not to dismiss it, but that's why everyone is then different, because everyone reacts differently, just the same way everyone reacts differently to embarrassing scenarios. So that's kind of how we think about it.
Hi, my name's Karen, and I have sub-Q, and I also have sight problems. This is 5 days old, and I have hot needle pain for about 6 days. And then it stops and it's very hot around the site. I've used many different adhesives because it also, depending on where I put it, I get these tiny little blister bubbles. And they itch really bad, like a terrible mosquito bite. And and it's around the adhesive, but IV 3000 is the one that I've been using. But I can't use that. The one that you just held up, the hypoallergenic, I think is going to be too hot. I don't know. I haven't tried it, but with all the oxygen covering it, because right now I cut the IV 3000 with the sub-Q. I just put it on the white adhesive, in a square. That way I can just turn it and snap off the quick set. So that's what I've been doing, but it's just so painful and so frustrating and annoying.
Yeah, I think you're bringing up one of the biggest things that we have to worry about is that when we use subcutaneous Remodulin, it has a lot of advantages because you can, if the site comes out, you can put it back in yourself. If you were to have one of the intravenous catheters, you can't put that back in. It's an emergency and requires us to get you to that medical help in order to put it back in. The subcutaneous pump is smaller, but the thing is that a lot of times with the medication infusing under your skin, it can be painful. It dilates blood vessels right around where the site goes in because that's what we want it to do, is to dilate the blood vessels in your lungs. But people sometimes get some swelling there. They also can have some discomfort there. And people experience site pain differently. Some people don't have any at all. Some people have a lot. And there are a lot of things that your doctors can do to help you tolerate the site pain. There are medications that we can use. Deidre's got a whole bunch of tricks up her sleeves to try to help with it, so it might be helpful to talk to her afterwards. But that's something that we have to worry about. But we can work with you with that. And if the subcutaneous system just doesn't work out, there's always IV as well. So we've got lots of options. Who else has a question?
Hi, my name's Jenny. I came to this session for one reason, and I have my site. I have intravenous, and my site is right here, as you can see in anything I wear. If it's not up to here, then I'm, so I was wondering about different dressings, or even I'm stuck with the site, which is right in there. Yeah. It's like I've seen other people here and here, or even back here. So is that something insurance probably wouldn't cover if I were to ask my doctor to have a site remove it? When this Hickman's working totally perfect. Yeah.
I think it's something you could, one, totally talk to your physician about.
Okay.
It's your life.
Okay.
And so there's some things that can be done. You can always take a look. There are different types of dressings you can use. You do bring up an excellent point because there may be people here, and I appreciate you bringing it up, for people who may be looking at going home and starting an infused therapy. I always tell my patients, especially female patients, when they're going to put that Hickman in, it is your Hickman. It is not their Hickman. It is your Hickman. And you have a nice discussion with them about where it goes, because there's different real estate and you don't want it against sensitive areas. Or for men, even if you've got a little bit of a hairier chest in one section, it's yours. So they can absolutely put it in different spots, either over to the side. There are a few people that they've tunneled it to the literal side of their body. So okay. There are different options for sure.
Yeah. Thank you. And one thing I wanted to say about I use the bio patch in my dressing. And I don't know how many of you used that, but I went for like a year, and then I developed an allergy to it, and just, I had to stop using it. I just use regular gauze, so that might have something to do with the little red bumps. It sounds like it could maybe be infection.
And I think it's kind of, as Deidre referred to, when we start folks on these medicines, we do tell people that these medicines will change your life. And these medicines will change your life in a good way, because the aim is obviously make you feel better, make you do more, hopefully let you get you to live longer. But they'll also change your life in a difficult way, in a challenging way, with the side effects that come with it. And just to kind of touch on them, we've touched on a lot in the sites, the site pains and discomforts. The other ones then primarily being jaw pain is one that people can experience, and the facial flushing, as well as some nausea as well. Some people feel a little indigestion. But again, the goal of these is obviously to make you feel better, make you do better. But unfortunately, in the current era, there are still side effects that come along with these by how they, and that's not being dismissive. But it's important to talk to the folks who care for you, your team, your nurses, your MDs, as well as Deidre said, the loved ones around you to try to make this work for you.
And I think it's important also that when you're going to start a new medication, be ready for a learning curve, because we're learning from you as much as you're learning how to do the medication, because we've never used the medication with you, for you. And so we learn through that process what dressing is going to work better, especially I think with subcutaneous. I've had patients before that were like, this does not feel good, this hurts. And I say, okay, wait, let's try this, let's get it settled. I had one patient that was about week 2 or 3 and said, I just don't think I can do this. And I said, come on, give me a month. Let's work it out together and figure out what's going on. And she's been on it now for years and years and years. And when I talked to her about 3 months after she'd started, she said, you're never taking this away from me, because I can do more now than I could ever do before.
I've heard a little bit about patients transitioning from a pump back to oral. Is that mostly lifestyle driven or medically?
So transition from the pump to oral, of course, everybody wants that, right? So the treprostinil now comes as a tablet form, and we did look at some patients who were on, had been on IV therapy. But remember, I told you in the beginning that it's the sicker patients who are getting IV therapies now. So these were patients whose pressures had come down nicely. On the ultrasound, on the echocardiogram, their right ventricular function was looking quite normal, and functionally they were doing well. They were able to do most of their activities of daily life without symptoms. So those select patients were then switched over to tablet form, and some of those patients have done well. But we've also learned, having done dealt with infusion therapy for over 20 years, that every now and then patients get switched from IV to other type of tablets, or sometimes patients have disconnected their therapies themselves because they're just fed up. And we've noticed that patients can do well for a period of time and then start to decline even after a year. So right now we've switched some patients from IV to tablets, and then we're watching them for a year or two to be sure that transition is going to hold, because I don't think when we switch somebody who's that well from IV to tablet, I don't think they're going to do this, but they might do this. And I'm not sure if this is good enough. Maybe it's not going to be. So that's the question we have to answer. Having said that, for patients who are having recurrent line infections, or cannot tolerate the subcutaneous anymore because they've been on the pump for 15, 20 years and have their function is recovered, then definitely the tablets do offer an option. So we do have something more rather than, we've run out of things. So it's still work in progress. Personally, in my practice, I discourage patients from just switching unless there's a good reason to switch till we learn a little bit better about it.
I had a support group meeting about a month ago, and one of the group nurses with this pharmaceutical company looked at my site, and I use a BioPatch, and she said, why are you using a BioPatch? It's not doing you any good. And I was taken aback by that, because for me it's an extra little pillow of support for my line. But I didn't understand what she meant by it wasn't doing me any good. Could you maybe take a guess what she meant?
I'm not
Because
sure.
my thinking was, well, then why do they make them?
I would say everybody's looking at the nurse.
Always have the answer.
I think it kind of depends. Do I have patients that use the BioPatch? Absolutely. Were there some studies that showed that the BioPatch was helpful for some people for site infection? Absolutely. Do I have some patients who don't use the BioPatch? Yes. A little bit off of preference. And also, it's that BioPatch is impregnated with some of that medication we use to sterilize that area. And so some people can end up with, I don't know if I really want to say an allergy, but more of a sensitizing issue where they can have problems with that. So, I think it kind of depends.
On the person.
But if you like it and it's working, great.
And this is also why we check in with people all the time, right? And folks who have the chronic infusions, come to clinic, within the first month after starting, and get phone calls every other week, at least in our program, checking in with them, seeing how they're doing. You have the specialty pharmacy checking in with people, seeing how you're doing, because all of these things, to speak to Deirdre's point, all of these things are unique and unusual. So I think it's important to try and figure out what's working for you and what isn't. But so I think that's just important to bear in mind. This kind of distinguishes it from everything else, right? When you have coronary artery disease, you get started on aspirin, statin, beta blocker, ACE inhibitor, and everyone's on that, and everyone stays on that for the next 30 years. And it's all very standardized and similar doses, and that's not what we have here, and that kind of makes it challenging, especially when you're trying to come to terms, especially in those first couple of months.
You have problems, with central line infections occasionally. What's the latest, in terms of like you start running a mild fever, and actually what you have is just a sore throat, and now you've got a fever of 101, and you've got your central line. Is the standard of care to pull that catheter at this point, or?
Yeah, it would. Yeah, it would be to pull that catheter, and this is why folks, again, when you're starting your infusion therapies, there's a commitment on folks who have this disease to dedicate their lives to being on the medicine, and also there's a commitment on your care team to actually be there for you. So when we get the phone call, and Nate's here with who's in our clinic, when we get the phone call at 9 o'clock in the morning in the scenario such as you're describing, where you have a temperature of 101, those folks come into clinic that day, and ultimately oftentimes get admitted that day. The line comes out, and then antibiotics are started. So that's kind of the standard management.
Yeah, unless it's like, you have a viral infection. I mean, it's the assessment of the patient, of the physician. If there is suspicion that the line is infected, then of course we want to take it out as soon as possible. But on the other hand, if it looks like you have a, flu-like infection going on, then you could just be, the patient could just be put in the hospital and observed, and then a decision made. But anytime there's suspicion that it is the line that is infected, we try to pull it out sooner than later, because we don't want that infection to get out of control.
And we check blood cultures a lot of times, as we draw blood from, your veins to see if there's gotten to be bacteria in your blood. But I would say one of the most important things that we can say is let us know when you have a fever. Don't just sit at home saying, well, I just got a cold. We always want to know about it.
I have a question about half-life of remodeling. What exactly does that mean? Can a patient be without remodeling for 3-4 hours, or what exactly does that mean? Is there a hard stop?
So what happens is, so when we look at epoprostenol, which is Flolan, which is the original medication, if it is turned off, it's pretty much gone from the bloodstream at about 5 minutes. The level is so low that it doesn't matter, like it's not effective anymore. So with remodeling, that period is longer. It's about 3 hours. But how much can a patient tolerate that interruption for how long doesn't mean 3 hours. It's a little bit better than for Flolan, but suppose you're getting the infusion and your blood level is here, and the remodeling infusion gets turned off. Initially it drops. It doesn't go down completely, but there'll be an initial drop. And a lot of patients on remodeling can tolerate that initial drop, unless, there's some patients who are just sicker. Even a little bit change might affect them adversely. So it's not like you can be off the medication for 3 or 4 hours, but remodeling does allow you a little bit more time off without declining as compared to epoprostenol.
And I think it's always important to talk to your physician, because they understand you. And whereas we have some patients in our practice, they continue this 100% all of the time. In a shower, through the shower, all of that. Now, I know that there are some differences that happen and different practices that people will do, saying that you can remove it for a short time during the shower, but that's really up to talking to your physician, not necessarily going to support group or someone else saying, hey, I take it off, no problem. I would always be careful to tell you, talk to your physician, because they understand you better.
How much time one can tolerate of any of these medications really depends how much your body, the right ventricle has recovered, like how much have you healed. So patients who kind of, improved quite a bit on these medications, their echocardiogram starts to look normal, and the medications gets interrupted for some unforeseen reason, they can tolerate prolonged periods of it. It's not what we want, but at least they will not crash and burn. But then if the heart's still very, not that improved, and you're very dependent on the medication, then even short interruptions can get people into trouble. So that's why nobody wants to just take it off on their own.
Which is why in the setting of an accidental interruption, such as, it falls out, etc., and you're not able to get it back in, that's why the recommendation obviously is to come into your local emergency department or local hospital and then get evaluated. And this is, in particular, again, your team, that's the pulmonary hypertension team that you're seeing is important, and they'll be, that you have a very good relationship and you have access to them 24/7, as well as folks like Accredo and CareMart, so that, because you can be on, frankly, you can be on vacation, in Yellowstone, say, you know what I mean, and then you get to a local ER and folks aren't familiar with what's going on, and they may say, well, your blood pressure is low, so let's stop this altogether. So that's kind of why when you start these medicines, it's important to have the phone numbers of the people that you see, have the phone numbers of Accredo and CVS, have all of these readily accessible, so that if you end up in an emergency department, you have a card or a phone. They say, listen, don't let anything happen without calling, Deedre, Lynn, Namita, John Ryan, something along those lines. And because he's a very angry Irishman and he'll be very angry with you. And so something along those lines, because you are, as Deedre said earlier, you are in control of this, and you have more experience with this medicine than your emergency department doctor in very rural America.
And we can help. So I always try to tell patients, I carry a 24/7 pager, you page me, because I have spent multiple times on the phone talking to the nurses and doctors in another facility, helping them to help you.
Go ahead.
Any feedback on the implant pump?
Yeah, I'm real excited about the implantable pump because I think it offers people something besides the lines. I mean, what happens is what we're talking about is there's a pump that's been out there for some time that's used for other medications. Sorry, I talk quiet. Are pumps that have already been approved for delivering other medications, but what we're talking about is putting in a pump that's about the size of a hockey puck, and it goes into your abdomen, and that medication is then, the pump is then filled with medication, and then there's a line that will end up going underneath your skin all the way up to where it needs to go to get the medication directly into your heart. It is probably still months away. The pump has been approved, but it's the line itself that goes from the pump to the blood vessels that they're waiting for to get approved. But even like last night at one of the shows, there was a woman that had it. And so I think it offers options for the future, and I'm real excited about it. You too.
So the other thing on new pumps, is there any news on replacement for the Chrono 5? Lots of people are sad about the impending demise of the Chrono 5.
I have to be honest, I'm not sure that I know the answer to that one as well. The Chrono 5 is not a pump that I have used a lot. We tend to function more off of the CAD Legacy and the CAD MS3. There are a few people that are really attached to their Chronos, though, I know that.
Yeah, and there's no more startups on the Chrono 5, as you know, and but Accredo and CVS do have some in stock. Can CVS not, if that's the case? No? They're all out? MS. Yeah. So, but it's very challenging.
We have the Chronos. The problem is we don't have replacement parts.
Yeah.
Yeah.
Oh, okay.
Yeah. And I think the reason those pumps didn't, I know a few of my patients love it, but the reason they didn't get so popular is, number one, it's a very concentrated, remodeling. So when we have to titrate up the medication, it's, big jumps. So patients who need titration, it wasn't very practical. And also it's, we get nervous about patients going to other emergency rooms with the CAD and the other one, but at least people are mostly familiar with those pumps because they're used for other indications. The Chrono was a very alien pump to a lot of physicians, so I think there was a little discomfort amongst physicians that when patients ended up in ERs which were not familiar with this pump, it would just be more crisis.
Hi again. My husband just texted me a while ago and wanted to ask two questions. One, okay, so I have a central line, Hickman catheter. How long, if I do not get an infection, can I have it for like 30 years?
It's yours.
I plan to be around for at least that.
I don't know if
Bought,
any
sold, yours.
I haven't had any last 30 years, but I have had one last 7 or 8 years, believe it or not. But we had trouble getting it out after that.
I have one that went 15 years.
Okay.
And it was the original one, and it stayed.
Okay, and then to follow up with that, can my physician, my treating, or my special, you know what I'm talking about, my page doc, my guy, can I go to him to inspect and see? I mean, should you get like the surgeon who put it in to inspect it, or nothing? Just go, if it looks good, it's good, and if you don't have a fever, don't worry about it.
So long it's working, it's working.
Okay.
I've had my original catheter for 8 years, and I haven't had any problems. I've had it patched a couple of times, the line, but that's it. I just wanted to let everybody know, I wouldn't recommend it, but I fell into the pool last week with my pump. A $50,000 machine, fine. $130 phone, dead.
Any more questions? We have 10 minutes left.
Hi, great talk. Was wondering if you could comment to the physicians and care teams in the room your titration schedules that you typically do once someone's been dismissed from the hospital in the outpatient setting.
Yeah, it's really hard, and as you probably know, it's an individual type of up titration. We usually start, around 2 nanograms per kilogram per minute, and we'll end up going up more aggressively while they're in the hospital, just to kind of see how they tolerate it. But outside the hospital, usually it depends on the medication and how many, the weight of the patient and how much we're going to end up going up every time we, make another notch. Sometimes once a week, sometimes more frequently than that.
Or it depends on the patient's side effects. I mean, this really is, ultimately, like she mentioned, it is personalized to the patient, from the type of pump we choose, what dressing the patient can tolerate, what dose they are going to require to get better, and how much sort of the interruption, if it happens, which we don't want, but if it does happen, how much can the patient tolerate? It really is very dependent on each individual patient, so there's no right answer. I mean, 2 of us might end up doing it completely differently, but because we're dealing with 2 different patients, it's not that we disagree that much.
Yeah.
Thank you. Nice to. Just wanted to know, like all 3 of you, like how high remodeling can you go up to?
There's no upper limit.
Like your patients, how high like you have your patients? The maximum dose of remodeling.
Probably. We've seen it up to 100 nanograms per kilogram per minute.
But I think it just depends on the patient.
Yeah. There are doses, there are patients on very high doses, like 200 some, but I think most of, when you look at the national average dose, which is sort of collected by, the suppliers, average dose for remodeling has been 50, 60, 70 nanograms. But that's sort of average. Now, the longer the patient stays on it, they might end up on higher. Also now with other therapies being available, the tablet forms, those being added in conjunction, probably hundreds is going to be closer to when somebody's been on chronic therapy for 4 or 5 years.
Yeah.
Okay, thank you.
There's our lady with the baby has a question.
Oh, right behind me.
Yeah. One with the cutest person in the room.
I just wanted to make a quick comment. We live in the middle of nowhere, and sub-Q Remodulin can be started in-home. I haven't heard that commented yet. So ours was started in-home for our 3-year-old daughter by our pharmacy, a CVS Caremark Pharmacy, and props to Lori, our nurse, who's sitting down front. So they have flown her out to us, and she's been to us 2 times, and another nurse was sent out another time. So that is possible too. Our closest pediatric place where they even take any peds kids is an hour away, but commonly we're sent 2.5 hours away to Duluth. We live in northern Minnesota, so I say that to offer encouragement to people that it doesn't have to be really scary, and it's possible.
And absolutely. I think that every single patient is different, and depending on where they are. I had a patient who lived up on a mountain called Blizzard Lane. And he started in the hospital, but when he was home, we still would send people out to see him. And he literally, as we would go to send somebody, said, well, can't they meet me in town? Because if they come up on Blizzard Lane, they're going to get stuck, and I'm going to have to pull them out. And I said, no problem. We'll meet at your work. Come on into town.
Well, we're down to 5 minutes. Is there any closing thoughts or closing questions you can think?
I guess my closing thought would be, you guys are amazing. Ask me if I know how to mix Remodulin or program a pump. The answer is no. And the fact that you guys can do this is absolutely amazing. And I think that it's amazing what people, the skills you can learn and the comfort level that you can get with it. And it's just a matter of knowing what the risks are, the medication, what your side effects are, and always talk to us when you've got a problem, when you've got an interruption, when you're in Canada and you've forgotten your supplies. We've had all of those types of things happen. So just know how strong people you are and how much of a resource those around you can be.
And I would add, similar to what Lynn is saying, that although we've emphasized that it can be very different and people's reactions can be very different, your PH team, by and large, what's happening to you, has happened to other people before. Other people have been through this. There's a lot of support systems there for you, be it with your PH team, with the Credo, CVS CareMart, etc., PHA even as well, and most particularly. So really just reach out to people and don't suffer in silence.
And I can't part without making sure to remind you guys that you are in control, and it's your life and it's your pump. The pump doesn't have you, and we do all of this so that you can live your life. I have a friend that's on IV Remodulin, and we want to cruise outside of the country, and my goodness gracious, I picked up her oxygen concentrator and we were in a dance line down the cruise. So play it and live it.
I agree.
Great. Thanks, guys.
Thank you.
Appreciate it.